Well, good morning, and thank you, Linda. And I really just wanted to call a big shout out to our invited speakers today, Dr. Morgan and Dr. Tanzi, because they really have set up the stage. I essentially have to do nothing. So again, let's give a big round to Dr. Morgan and Tanzi. So I think that's wonderful, but everybody does want to know, and what is really special about Sanders Brown, I think is really embodied in the talks today. Really, the basic science, all of the researchers making discoveries, but then we have to bring that home at the end of the day, right? We've got to bring it back to people and make a difference in people's lives. So that's really what we're going to talk about here today. So I did want to just touch base briefly on this concept of disease-modifying therapies. So we've had symptomatic therapies since the late 1990s. Medicines like donepezil, Aricept, rivastigmine, Exelon, and memantine, Namenda. And symptomatic therapies are great. So you can see it in red or orange, depending on how colorblind you might be. We can see what a symptomatic therapy might do. It might give us a little bit of improvement. It's certainly going to delay and slow symptom progression, but at the end of the day, it doesn't change the disease, meaning we end up in the same place. But disease-modifying therapy, changing the disease itself, alters that trajectory, not only delaying symptoms and giving people additional quality of life, but persistent effects. We've changed the disease itself. And if we can change it, we can end it. And that's beautiful. So again, before we get into, the clinic here for anti-amyloid therapy, I do just want to say there's always going to be a place for these symptomatic therapies. And so this is work from our own Dr. Pete Nelson years ago, looking at, and Dr. Abner, looking at that slope of decline in patients with Alzheimer's disease, whether or not they were on a medicine like Aricept and donepezil. What you can see is that these symptomatic medicines also delay symptoms, delay progression to a mini mental of 15 by a year. That's pretty important. What's a mini mental of 15? Well, that's about the amount of time or the score when someone could no longer be left alone at home. Well, delaying that by a year is fantastic. They can hang out by themselves, engage, delay by 2 years to reach a mini mental of 10. That's about the time where somebody needs 24/7 supervision and care. So that's meaningful. So I want everybody to know, we'll always be using these other medicines, but the paradigm, the game changer, and I'm not going to go through this timeline because Dr. Morgan really was at the forefront in this battle, moving this research forward that has been a 25-year journey. And so I think I've captured some of the high points here, but I do want to let you guys know, I came here in 2005, and shortly thereafter, with the first human passive immunization studies, we have been working not just in the laboratory, but with people directly. And so almost 2 decades of experience treating human beings with these different medicines. And that's really, really important. You can't get that kind of experience anywhere over time. And so of all the different places where these medicines can be implemented best, safest, and most appropriately, really Sanders Brown is at the forefront of that. So people have argued again, how much time will this buy us clinically? And there's a lot of debate in the field. There's really no doubt that's really been quelled. There was a lot of discussion early on, but people have come to accept the fact that when we say a 30% slowing, we're looking at up and down. What we need to be looking at is side to side. How much additional time, and if we can get to people, if we can diagnose them early enough and give them these medicines, there's a potential to add years of quality of life. And I always say that's the importance, right? If I was diagnosed with terminal cancer right now and they said, I've got a medicine for you that could buy you an extra year, it's going to make your hair fall out. Well, you guys will be looking at a bald Dr. Jicha next year, but you'll still be looking at me. And that's wonderful. And these medicines are meaningful. As we saw in that philanthropy video this morning, just a little bit more time with a loved one is valuable. So I think there are some critical issues. I'm not going to go into all the data. You saw that today. Dr. Morgan did a wonderful job presenting that. But I do think we need to begin to think as a community, these medicines are not going to be for everybody. So they're only going to be for people at the earliest stages of disease. We don't yet know what kind of benefit at later stages of disease. It appears that the more the disease advances, the less effective they are. I think we're going to learn a little bit about that. But for right now, we do have and already are seeing a lot of folks come forward who are too impaired, that they don't really meet criteria for the medicine. So again, it's important, if you know somebody with early memory problems, get them in to be seen, to get that diagnosis, to get that treatment. I think we need to think outside of the box, as Dr. Morgan showed today, this ARIA, amyloid relating imaging abnormalities. And I was at the first meeting, Risa Sperling from MGH coined that term. I was at that meeting where we were discussing it. And I said exactly what Dr. Morgan said. ARIA sounds too nice. That's like an opera. We should call it something nasty because this is harmful. Swelling in the brain, bleeding in the brain is harmful. You have to have an MRI because so many people are asymptomatic. Would they become symptomatic if we didn't see it on an MRI and continued to treat them and their bleeding got worse and worse and worse? Yes. So we really need to think about that. Now, what can we do? We do have folks that come in sometimes and they may have metal in their body. And we'll talk with them. Your pacemaker's an old one. You can't have an MRI. Maybe you should talk to your doctor because you're going to need it replaced in a year or two anyway. Let's replace it now. Had a young gentleman come in with a little bit of metal in his orbit. And if we put him in the MRI, it might pull that metal fragment right through his eye or through his brain. So what I do, I sent him to plastic surgery and said, can you take this little piece of metal out of his eye? In the office with a little bit of Novocaine, they made a tiny little incision that required one stitch, and they used a magnet to pull that piece of metal out. Now he can have this medicine. Isn't that wonderful? So again, we come together, we think outside the box. We do need to use caution for patient on blood thinners, and there are many centers that are not going to provide this medicine to people on blood thinners. Not aspirin or Plavix, not antiplatelets, but true blood thinners like Coumadin or Xarelto, Apixaban, things like that. We do have to think about that because a microhemorrhage, a tiny little microscopic hemorrhage, could become huge if you're on a blood thinner. So are there ways to get people off of blood thinners? And there are. Some folks with atrial fibrillation can be sent to the cardiologist for procedures like a Watchman device that make them safe to come off of their anticoagulants. Again, pulling together and thinking, how many people can benefit from this? Let's try to make as many as possible able to receive these medicines. I think that's important. We do need to use caution. People with especially 2 ApoE4 genes are at higher risk for ARIA, swelling or bleeding in the brain. Again, knowing your genetic risks so that we can discuss what is your risk of those problems. How carefully do we need to watch you, I think is important. And then realizing, it's really wonderful, that this is the first drug approved in July 6th, just this year, a few months ago. And Medicare has said that they will pay for it. They're a little slow with the billing codes and everything else, but that is currently all in place. If you only have basic Medicare, then you may have a substantial copay, and you really need to think about that. We're right now in the Medicare enrollment period. So if you think you might need this medicine, you best call right now your Medicare Advantage plan and say, are you going to help me cover this? Because I don't have an extra $5,000, $10,000 a year in my fixed budget. And you might be able to switch your Medicare Advantage plan to be eligible for this medicine without out-of-pocket expenses. Really, really important. So the real heart of the matter that I want to get at is, again, something that Dr. Morgan talked about. These are not the end all. This is not the cure for dementia. We're talking about slowing in about a 30% range. So slowing the disease, a 12-year duration disease, by about a third is wonderful. That's years of extra time. But why? And so one thought is, well, maybe we need to be treating even earlier, as was alluded to earlier. When there's only amyloid, what if we can get rid of it then? And the other is, there's a lot going on in the brain: inflammation, other pathologic proteins, tau, TDP-43, alpha-synuclein. These are two possibilities, and we really don't know the answer yet. But I will say this: we are already working on this with the AHEAD study. People who are normal, 1 out of 3 people over the age of 65, already have a buildup of amyloid in their brain. We're screening people with a simple blood test. If it looks like they may be building up amyloid, we're sending them for a PET scan. And then they have the ability to enter a trial to use these medicines experimentally to see if it could delay, as Dr. Van Eldik talked about before, or potentially even prevent Alzheimer's disease if there's nothing else going on in the brain. So I encourage you all, there are AHEAD flyers out there. If you're interested in becoming part of the fight, and it does take a community, please pick up one of those flyers and look at this. The other issue is, do we need other medicines? There's so much else going on in the brain. And I would argue that we do. And so the little graph on the bottom right corner of the screen is brilliant work done again by Dr. Abner and one of her students, Shama Karanth, looking at people, how many pathologies do they have in their brain? And they really coined the phrase QMP, quadruple misfolded proteins, which is at least a quarter of all dementia cases have all 4 proteins, not just Alzheimer's disease, cooking in their brain. Maybe we got to get rid of all of those. Really, really important. So now's the time where the field has turned, and we've turned at Sanders Brown, thinking, what else can we add to anti-amyloid therapy? So there are medications out there, still experimental, but working to target tau, working to target alpha-synuclein, Lewy body disease, Parkinson's disease, working to target TDP-43, the only trial in the world targeting TDP-43 right here in Kentucky, nowhere else in the world. Absolutely fantastic. Targeting vascular disease, protein misfolding, metabolic dysfunction, lifestyle. These are important. So here we are. Dementia now and dementia in the future. So we've worked on A beta. We're doing good. How about getting rid of tau? How about getting rid of aging? Believe it or not, we have a vaccine trial, an anti-aging vaccine study. You guys laugh at this. It's real. And what about metabolic dysfunction? Well, we're working on that. What about lifestyle impacts? We're working on that. What about toxic protein shapes, Lewy bodies, cerebrovascular disease, TDP-43? This is what dementia will look like in the future. That is when we will have done our job. And there was a vicious rumor that I'm retiring. When we accomplish this, I will retire or look for another job. But at the end of the day, isn't that worth it? Isn't it worth it for our children, for everyone that might suffer in the future if we didn't do this work? So let's pull together like the community we are, incredibly powerful. We can do this. Sanders Brown can't do it alone. We can do this with you. We can do this with the other scientists across the nation and the globe. We can do this with everyone working together, and you're part of that. So thank you for coming this morning.